It's the first time I've used this laptop that way, and I was worried that I don't actually have an internal microphone. So I didn't know.
She was like going through
I'm having pass that around. We have a dead. It is time for us to get started, and we have a dead microphone, so I'm just going to talk loud. I have a good, strong voice, so that should not be a problem. I would like to start class with a word of prayer. Father in heaven, we invite you to be with us today. We are on home stretch for this quarter, but we still have much to accomplish. I pray that you will be with each student in this class, and that you will give them guidance and strength to finish the course, the quarter and all their courses with distinction. I pray these things in Jesus' name. Amen. I have an attendance sheet circulating. I would like it to go around quickly. I will be picking it up in 3 minutes. I have had questions about the final exam. So this final exam was left off the schedule altogether. And we discovered that right at the beginning of the quarter, and it took a while to get everything arranged, and that's why the final course schedule was late getting to you. But then the person who schedules the exams is out on medical leave, and apparently the 5th floor doesn't know what's going on for your class because they had to move several finals. So they're working on that, and as soon as we get everything confirmed when all of your finals are for this quarter, we will let you know. But the information that you have in your course syllabi is what we negotiated, and I even have room reservations for it. So we expect it for Thursday. The only way we can do a Monday final for this course is if we drop our last topic and have no class next week, because I will have to drop everything in my schedule next week to even get it done that soon. There's absolutely no other way we will have a final exam. So, and that's, the final exam for this course has been on Thursday morning for years and years and years, because of the 2 different types of questions. It's like making 2 final exams. And so it's a lot of work for us, and we have new material up through Friday of the quarter, so there's no way to get it done early. So, and I know some of you need extra prep time, extra study time as well. So we will see what happens, and I honestly don't know yet. So we have a new topic for today. I'm going to try to do an audio recording with Panapto. I did that once with my new laptop, and I don't think it picked up the audio, so we'll see how this goes. Our new topic is diseases of bone. Our bone diseases of the jaws is an important topic, but one that tends to be a little bit challenging for our dental hygienists because you're not used to looking at the jaws comprehensively. We don't ask you to learn nearly as much as the dental students learn. We ask you to learn more common, important, and distinctive things that we think you can figure out and recognize as dental hygienists. We have already been looking at jaw lesions. We have talked about pulpal and periapical diseases. We've talked about jaw cysts and odontogenic tumors. So what we're covering in our bone diseases of the jaws are the remaining things that are not of odontogenic origin, basically. Not cystic and not of odontogenic origin. So we have a miscellaneous group of disorders. Some of these are very common, some of them are less common but very important. Many of these have skeletal counterparts. Some of them are unique to the jaws and only occur in the jaws. So we have an interesting group, and we are going to kind of do them in etiologic categories. So you'll want to pay attention as we go through which etiologic category they belong to. There's one group that doesn't follow the rule of being in etiologic categories, and I'll explain that one when I get to it. I'd like to pick up that attendance sheet very, very quickly, so if you could speed it along, I would really appreciate it. So we're starting with our disorders that are metabolic bone diseases. So these are derangements in normal metabolic systems that affect bone physiology. And although there are a variety of things that fall into this category, not many of them specifically affect the jaws. What is the most common metabolic bone disease? I bet you know, even though you probably never thought about it that way. Osteoporosis, absolutely. Osteoporosis cannot be diagnosed on the basis of dental radiographs, and so we're not going to cover it. There are only certain areas in the body where the bones are calibrated, so they have density studies that they can do that produce meaningful and diagnostic results. But we can see changes in the jaws in patients who have osteoporosis. We just can't diagnose it that way. So we're going to talk about something that we can reliably see changes in the jaws, and that's hyperparathyroidism. Have you talked about hyperparathyroidism at all in your medically compromised patient course with your endocrine disorders? Yes? All right. So you know that this is a disease that is characterized by persistent elevation of parathyroid hormone. We have 4 little parathyroid glands on the lateral edges of the thyroid, and they produce 2 hormones, parathyroid hormone and what's the other one? Calcitonin. Right. So hyperparathyroidism is the disease that is produced by persistent elevation of parathyroid hormone. It occurs in 2 situations. Primary disease, which we would call primary hyperparathyroidism, is the one that's caused by a functional tumor, usually a benign parathyroid adenoma that produces hormone, and it just is not linked to normal feedback mechanisms, so we have persistent release. And the other is compensatory hyperplasia of the gland, where there's persistent production of parathyroid hormone to compensate for the effects of some other disease. So what is the function of parathyroid hormone? What does it do?
Increases blood calcium.
It liberates calcium out of the skeleton because bones are a reservoir for calcium, and it liberates calcium in order to maintain normal serum calcium levels. We need calcium for a large number of normal processes in the body, and we have actually a very narrow window of normal serum calcium levels that need to be maintained. So if serum calcium is low, parathyroid hormone goes up, liberates calcium until we get back in the normal range. Patients with primary hyperparathyroidism that have a functional tumor, it's not linked to those normal feedbacks, so they are always going to have hypercalcemia. Their blood levels of calcium are always going to be higher than normal. Patients who have secondary hyperparathyroidism get the compensatory hyperplasia because they have some underlying disease that's depleting calcium. Typically, it's a kidney disease where the glomeruli are not functioning properly and they're just peeing out all their calcium. And so the body is constantly liberating calcium from the skeleton to replace the calcium that's being lost in the urine. So those are the 2 different ways that we get it. Regardless of if we have primary or secondary hyperparathyroidism, they produce the same changes in the bone. And the bone has its own name, the bone disease. So the parent disease is hyperparathyroidism. The name of the changes that occur in bone because of hyperparathyroidism are called 2 names. Either hyperparathyroidism of bone, so everybody knows you're talking specifically about the bone changes, or osteitis fibrosis cystica. Which of those is easier to learn? The first one. So feel free to use it. World Health Organization likes those Latin-based terms. Makes no difference to me which one you use. If you are constantly taking calcium out of bones, you are weakening your bones over time. So the major radiographic change throughout the skeleton is trabeculae that lose distinction. So instead of having distinct normal trabeculae, they kind of disappear and we end up with this fuzzy ground glass bone. And so that diffuse ground glass bone or frosted glass bone or orange peel bone looking appearance happens in all the bones, including the jaws. And because it's a body-wide metabolic process, it affects everything pretty uniformly. In the jaws, it doesn't affect the contours of the bones, just the radiographic bone quality in normal situations. There's one exception. In very advanced disease, where the osteoclasts have removed all of the bony tissue, that soft tissue that's left in the marrow sometimes kind of takes on a life of its own and behaves somewhat like a tumor and can proliferate and produce some expansion and outright radiolucencies that look different than the typical appearance. We call these brown tumors of hyperparathyroidism. They're not really neoplasms. They're just kind of over-the-top areas of damage to the bone in hyperparathyroidism. So this is what we would expect to see in a typical case of hyperparathyroidism, gradual transition to this uniform, stippled ground glass appearance of the bone. The thing that you notice besides the ground glass bony replacement of normal trabeculation is loss of the lamina dura. So the radiolucency that's there is kind of independent, or maybe a little more advanced destruction. But notice how it affects all four quadrants. That's pretty typical. And these are usually middle-aged and older patients. This is not usually a young person disease. The functional adenomas are usually middle-aged women. The kidney disease patients are usually older men. So this is something that usually develops well into adulthood. These are examples of patients who had hyperparathyroidism of bone for a long time and got those brown tumors of hyperparathyroidism. And you can see there's some expansion, and it looks like a multilocular lucency. And here you can see a distinct area of lucency and expansion. My good friend, Dr. Koltfarber, who is an oral and maxillofacial radiologist, has a saying that I've heard her say a number of times, she can have as many diseases as she pleases. Have you heard that before? We pay attention to that in pathology. Just because you find one diagnosis doesn't mean that's the only disease a patient has. So even in the setting of a patient with known hyperparathyroidism of bone, if you find these expansile lesions in the jaws, they have to be biopsied to confirm what it is, because they could have some other disease on top of their hyperparathyroidism. If this is a brown tumor of hyperparathyroidism, which is what we would expect, it's going to be very cellular granulation tissue inside, and it's going to be very vascular, and it's going to have lots and lots of multinucleated giant cells. What kind of cells are those? Think about it. In hyperparathyroidism, multinucleated giant cells in the bone should be
Osteoclasts.
They should be osteoclasts. They are osteoclasts. There are just too many of them. They're bored. They don't have anything to do because they destroyed all the bones, so they're kind of proliferating. When they did the biopsy with this patient, they actually removed a tooth, and this is some of that abnormal tissue attached to the tooth. What color is it? Brown. Dark brown. And that's why they're called brown tumors of hyperparathyroidism. The vascularity, the rich blood supply in these lesions turns them very brown. So they're not named after Dr. Brown, they're named after the color. They are literally brown appearing tumor-like expansions in patients with hyperparathyroidism. Yes?
Within those two, the brown and then just the classic presentation?
Yes. Which is more typical?
The classic.
The classic, absolutely.
I don't know what I was going to ask.
Okay. Treatment, real quick, if you've talked about this in your medically compromised patient course, the treatment for hyperparathyroidism of bone is definitely treatment of the underlying problem. For the primary, you remove the tumor, and slowly the bone returns to normal with appropriate vitamin D and calcium supplementation. With the secondary disease, you have to correct the underlying defect, which sometimes can be very difficult, particularly in the patients who have kidney disease, which is the most common problem. The only treatment for them might be a kidney transplant, and they might not be able to get one. So they do things to try to prevent destruction of bone, like really, really high levels of calcium supplementation. But even so, they often have ongoing damage to the skeletal system. And that is always treated by physicians, never by dentists. But we sometimes are the first to recognize in our field that a patient with history of parathyroid disease or maybe history of kidney disease is getting jaw changes that suggest hyperparathyroidism. So we could refer into the medical system for a workup. So we're leaving metabolic disease and going to genetic diseases, diseases that have a genetic basis that affect the bones. There are many, many genetic syndromes that produce bony changes. Most of those are rare diseases, and we're not going to talk about them. But there are a few that produce very distinctive changes in the jaws that we are going to talk about, and one of them is cherubism. So you know what a cherub is? Sure. And you know the cherubs, the little cupids at Valentine's Day with the little chubby cheeks and diapers. Why don't they put them in diapers? I don't know. But anyway, this is a disease that's named after that appearance of the chubby cheeks and the little eyes gazing into the heavens like a cherub. It is inherited as an autosomal dominant Mendelian disorder, which means the defective mutated gene is on a non-sex chromosome, which means it should affect males and females equally, but it does not. It doesn't follow the rules of Mendelian inheritance. It has 100% penetrance in males, meaning that all males who have the defect express it, but only about half to 3/4 of females who have the disease express it. So that just doesn't follow the rules at all. And so this is more common in males, even though it shouldn't be. It has early age onset, usually in toddlerhood, at least by age 5. By the time they're old enough to go to school, they should have some manifestations. Often around age 3 or 4 is when families first notice it. And it can affect all 4 quadrants of the jaws, maxillary and mandibular, but not always. It, however, always affects the mandible. It's a bilateral, fairly symmetric disease affecting the mandible and then sometimes the maxilla as well. And it produces expansion of the bones. So it's caused by a mutation in a gene that affects morphodifferentiation of the jaws. And instead of producing normal bone, it produces more soft tissue, and so it produces an expansile changes. The bone doesn't mature properly.
How common is this disorder?
Pardon?
How common is this?
It is uncommon, but it's common enough that you may see it, and it's distinctive enough you should know what it is. So it's not a common thing. It's not something you see every day.
So if this was my child, I wouldn't necessarily look at him and realize that something's going on?
You probably would. Because it's a dominant disorder, you should know it runs in the family. However, there are new mutations, and the rate of new mutations is fairly high. And so it can occur in a family with no known family history. But usually, one parent is affected, and they have siblings and grandparents who are affected. That's the typical one. This is a 13-year-old. He actually was a new mutation. He came from a family with no known history. And he just looks like he kind of has chubby cheeks, still has some baby fat on him. So he's not terribly disfigured. However, sometimes the amount of mandibular swelling is very disfiguring. And so there's a lot of variability in the severity. These are his radiographs. An oral surgeon put a staple hole in it, putting it in the chart. Don't ask me why. But you can see that there's some expansion this way. Notice how the ramus is wider than it should be. So you can actually see the expansion, and you can see how it's pushing out the inferior border. And the normal bone is replaced by multilocular lucencies of variable sizes and some trabeculation within. And it's posterior in ramus. So angle and ramus is the typical area of involvement. And the other side looks very, very similar. So it's fairly symmetric, and it's virtually always bilateral. If it's not bilateral, we do genetic testing to check for it. Therefore, and that's extremely rare. So any case I'm ever going to show you is going to be the usual bilateral, fairly symmetric. Within the area of abnormal bone, the teeth tend to float around and be malpositioned, and so they can have some occlusal and functional problems and require orthodontic treatment and things like that. Fortunately, the bone is adequate for structural support. We don't have problems with fractures, and this is not a disease that's treated by excision of the abnormal bone. This is a patient I saw some years ago, and you can see it's expanded and beautifully multilocular and lucent in the posterior areas, all the way up the ramus. And she's already in orthodontic treatment. This was a girl, and interestingly, all the affected patients in her family were women. Her mom, her mom's sister. Maybe they just only had girls in their family, who knows. But that's a really nice typical case of cherubism. So that's what it looks like. What diseases have you studied that have multilocular lucencies? Have you studied conventional ameloblastoma? Yes. Would that ever be bilateral and symmetric? No, because it's a neoplasm and those are solitary. What about odontogenic myxoma? That can be a nice honeycomb expansile lucency. Would it ever be bilateral and symmetric? Never, never. So the fact that this is bilateral and symmetric tells you it's not a neoplasm, and it helps you distinguish it from those things that are neoplasms. And the young age of onset also is very helpful to let you know it's a developmental thing. Question?
Would the disease cause like the back molars to not be formed, or were hers probably extracted?
Sometimes the teeth don't form. Sometimes the teeth form and don't erupt. Sometimes they erupt ectopically. So it does affect the dentition in the area. Fortunately, it tends to be more posterior and not a huge problem. It usually can be managed. Treatment for these patients is to let it mature. Because this is a developmental disorder that is linked to, even though there's a mutation, it's linked to growth regulation. So it behaves like a hamartoma. And when the patient stops growing skeletally, the lesions stop growing. So what we do is wait till it stops growing and then decide if we need surgical recontouring for aesthetic purposes or functional purposes. One of the things that has been learned is if you do surgery before skeletal growth is complete, it accelerates the growth of this tissue. And so we really don't want to do surgery prior to skeletal growth completion unless absolutely necessary. And a lot of patients, the bony enlargement is not such a cosmetic problem that they need to have surgery, but some patients definitely do. Okay. Who's going to do that surgery? Oral surgeon. Oral qualified, experienced oral surgeon. Yeah, not just anybody does those kinds of surgeries. So these patients are usually managed by a team of general dentists, oral surgeons, and orthodontists. We move on to another disease that has a genetic basis, something that you all know about, and those are tori and exostoses. How many of you have already seen those in patients? Yeah, these are very, very common. Some people don't know that they have a genetic basis, but there is definitely a genetic predisposition, and they do tend to run in families. They tend to develop in late adolescence, early adulthood, but they are kind of what we would call a disease of multifactorial inheritance, where environmental factors also affect development of disease, not just the genetic predisposition. So the local factor is abnormal physical stresses on the bone. So if you have excessive physical stresses on the bone in a patient who's genetically susceptible, you can get tori and exostoses. Once these form, they're usually very stable in size, but if something tips the scales and makes the physical forces more excessive than they had been, then they can start growing again. We have several different patterns. We have the midline palatal torus, which is in Latin terms torus palatinus, the bilateral lingual mandibular pattern, which is called torus mandibularis or mandibular tori for plural because it's always both sides or almost always both sides. And then buccal exostoses when these are on the outside of the jaws instead of the inside. Which pattern is most common? Did you study that when you learned these? The literature says palatal torus, and the literature is wrong. Everybody knows mandibular tori are more common, but they're often small and undercounted, so we need to do some new studies. That would be a great student research project, by the way, if you want to do it with me sometime. So, do you have trouble recognizing these? No. Palatal tori along midline. Sometimes you even see the midline suture groove in the middle. They can be multi-lobed, they can be small, they can be large. The mucosa over them is very thin and easily traumatized. And because these are normal to the patient, sometimes they don't look in the roof of their mouth and they don't know that they have something abnormal until they get traumatized. And it hurts, and then, oh, there's a big lump of bone. Oh, this must have appeared overnight. And they get very, very worried. And it's something that they've had for years. So we hear that story often. What do we do for treatment for palatal tori? Usually nothing. There are two reasons we need to remove them. One, they get so large that they interfere with speech and eating. Or two, we need to place a prosthesis. Removable partial denture. That's not a problem as much as it used to because we do a lot of implants, but occasionally we do need to remove them. Does a general dentist usually remove a torus? Yeah. Not usually, an oral surgeon, although it's a much easier surgery than it looks like it ought to be. These are some nice mandibular tori, and I love them. They often look like little multiple lobes, like a little string of pearls on either side. Don't you like that? Fairly symmetric. And almost always in the bicuspid area. And those mechanical forces that cause them explains this, because the bicuspid area has small teeth, thin bone. That's an area of the mandible that's very thin. And if you lose the posterior teeth, as this patient has, those weak bicuspids are carrying all that functional load. And so that stimulates the growth of the tori. So it's very common to see these in patients who are missing a tooth or have some misalignment of teeth that is producing some abnormal physical forces in this very anatomically weak area of the bone. Notice how up high they are. We see them on radiographs as well, and they're almost always up high near the alveolar crest. Is well-defined dense opacities. If you remove a torus and look at it histologically, it's just normal dense cortical bone. So they are always going to show up as a dense oval opacity.
So are palatal roots more just like developmental, or palatal tori, but then mandibular more reactive?
Palatal are supposed to be reactive as well, and we often see them in patients with missing teeth that we think there are increased stresses on the teeth. But sometimes not so much. So it's a little harder to explain them. We can see them in bruxers more. So we can usually have a clue that there might be some unusual physical forces. But it's a little harder to get them, I think. You have to work at it harder. I love them. Sometimes they can get really big and there's barely room for the caruncles, for that Wharton's papilla to sneak through. Do you notice the vascularity over the top? Would you ever confuse this with a lipoma? Yeah. Never. Do we get lipomas over jaws? No, they're in soft tissue. And all you have to do is touch one of these and you would never confuse it for a lipoma. Lipomas are so soft and these are bony hard. It's like knock on wood. So the location tells you there's no way it's a lipoma. So, beautiful buccal exostoses. This patient has them more in the posterior area, more in the mandibular area. Sometimes we remove these, and the major indication for removal of buccal exostoses is interference with normal oral hygiene routines. How do you brush and floss next to these? You're whacking it with the toothbrush all the time. What do? Get a brush with extra long bristles so you can work around them? I mean, it becomes very difficult. So when these are interfering with hygiene and promoting periodontal disease, that's when it's definitely time to get rid of them. And send them to the oral surgeon. They actually lay a flap, cut a little groove in the top and pop them off with a chisel, smooth it down. They actually separate. They pop off very nicely. It's not as bad a surgery as it sounds. So I have this in my teaching file, this lesion, from before I started teaching here that said this was an exostosis, and I don't believe it. Why?
There's only one.
Low? It's too low. Our buccal exostoses, like the mandibular tori, are usually under attached gingiva. They're up high in the alveolus where we are trying to support teeth. And this is way too low. And it's also on a tooth with a crown where it looks like there might be a little exudate coming out of the sulcus. So I'm going to bet money this is what? Something that we saw last week. Yes, when we had no PowerPoint. A parulus. I bet you if you poked a hole in that, that exudate would drain out. That's got to be a parulus. It's down over the root where you would get a dental abscess tracking to the surface. So the location, and if you palpated that one on the right, it would be slightly compressible. Bony exostoses are not compressible. So we move on to inflammatory disorders. We've already talked about our major inflammatory disorders. Some of them we're going to see again. What is the most common source of inflammation in the bones? Infection from a tooth. Spread of infection from a tooth. So these are almost always odontogenic infections. That's what odontogenic infection means, infection from a tooth. So we've already talked about that. We mentioned osteomyelitis as a complication of a dental abscess that's not adequately treated or isn't treated before the body loses containment. And so we had a little introduction, and we'll talk a little more formally about osteomyelitis. The word means bone and marrow inflammation, and it basically means that we have an infection that is spreading throughout the marrow spaces of the bone and into the bony trabeculae. And interestingly, a defining component of osteomyelitis is bone necrosis. So the infection actually cuts off the blood supply to the bone, and we end up with bits of dead bone in the affected area. Once we have infection spreading in the marrow spaces, it doesn't stop till it hits anatomic borders. What are the anatomic borders in the jaws?
The condyles.
The cortices at the edges, from all the way up in the mandible, condyle to condyle, upper body. It can spread very, very rapidly. And because we have much thinner cortices along sutures and maxillary bones, maxillary osteomyelitis can spread to skeletal bones. So it can be very, very dangerous. When we look at it histologically, we're going to see chunks of dead bone. How do we know it's dead? There are no osteocytes in the lacunae. They're empty lacunae. And at the edge, we see that the bone is being chewed up. We see resorptive lacuna, and we see infected material next to it. When we look more closely, if it's acute osteomyelitis, we see that the marrow has been replaced with lots and lots and lots of neutrophils, and we can even see some of the fibrin from the exudate, and sometimes we even see clusters of bacterial colonies. Acute osteomyelitis is much more common than chronic osteomyelitis in the jaws. If this is chronic osteomyelitis, when we biopsy it, we're not going to see any exudate. We're going to see an inflammatory infiltrate composed predominantly of plasma cells. So it looks different, behaves a little bit differently, but we still get the dead bone. It takes about 2 weeks of active infection in the bone to produce enough destruction of bone to show up radiographically. So patients usually, if it's acute osteomyelitis, are symptomatic during that time because the infection produces exudate, which creates pressure in the bone, which creates pain. But often it's kind of vague pain, difficult to localize, and so sometimes it takes a little while to make an accurate diagnosis and treat it properly, which is risky. Should be diagnosed quickly and by somebody who knows what they're doing. This patient came to the School of Dentistry and saw a student and didn't get diagnosed right away. So came in the summer, this is years ago, July 18, came in complaining of vague pain. They took this radiograph and didn't see a problem. Do you see a problem? I see a problem. This bone does not look the same. Does not look the same. So I think I would have figured that one out right away, but the dental student didn't, and the general dentist supervising didn't either. So the patient went home and kind of lived with this vague discomfort. And finally it got worse again and came back in November, months later. Now do you see changes? This is what we call a moth-eaten appearance, which is very typical for osteomyelitis. We get skip areas of bony destruction, areas of lucency, areas next to areas of fairly normal bone, and then more areas of lucency. We have widened PDL when we look. Come on, little pointer, the one in the middle. You're supposed to show up. This pointer there, well, it advanced. Anyway, there were some significant changes. The patient came back. I think they put the patient on antibiotics. Patient came back just a few weeks later, and it had really progressed. So from here, where there's some significant lucency, to here 3 weeks later, a lot more additional destruction, and now the interradicular bone in the furcation area is completely wiped out. And clinically, there's swelling of the overlying soft tissue, and there was exudate draining from a fissure next to the tooth. So at this point, infection's pretty obvious. Does the bone swell itself when it's infected? No. Not very much. Sometimes we get a little periosteal reaction and can get some slight swelling at the level of the periosteum. But usually if we have any swelling with acute osteomyelitis, it's the soft tissue overlying that's also infected and has some exudate in it. So at this point, when we have osteomyelitis, antibiotics alone aren't going to treat the problem. And the reason is the dead bone. The chunks of dead bone have lost their blood supply, and they harbor bacteria. There's no way for the antibiotics to get on the inside of those chunks of dead bone to get rid of the bacteria. So patients with acute osteomyelitis require surgical management and medical management. Do you know how long we usually treat odontogenic infections? If a patient has a bad abscess or it progresses to cellulitis, how long do we usually keep patients on antibiotics? Do you know? I know you don't prescribe that.
10 days.
A typical infection elsewhere in the body is treated for 10 to 14 days. Dental infections are usually only treated for 3 to 5 days. 5 days is about top. So you just want to control the infection enough that you can go in and treat the source, and once you eliminate the source of infection, then the rest resolves. So we don't usually do long treatments with antibiotics. That's rather unusual. Osteomyelitis is the exception. And because it does require surgical management and the antibiotic management is quite a bit different than most infections, these should always be treated by oral surgeons and not general dentists. It is always a referral. So what the oral surgeon has to do is go in surgically and curette out all the dead bone to get back to living bone. And usually they start with IV antibiotics. You may have to run a PICC line and have a nurse go in every day and give the IV. And after a couple weeks of IV antibiotics, then they switch them to oral antibiotics. When they go in and curette out the dead bone and the exudate and all the nasty infected stuff, they send part of it for culture. While they're waiting for culture results, the antibiotics they start with are going to be broad spectrum, and then if they find a better antibiotic on the basis of the culture results, they may change the antibiotic. But total time on antibiotics is often 6 to 8 weeks and up to 3 months. So it's very long treatment, and they have to change antibiotics every so many weeks so you don't get resistant strains. So it's a tricky business. And recognizing it early is always better for the patient, always a lot better. See, there's one of those chunks of dead bone that had to be removed. Sometimes they can actually work their way through the surface and slough into the oral cavity. So when we get those little chunks of dead bone that separate from the rest of the host bone, we call it a sequestrum. Can you see the exudate on it? Doesn't it look wet and juicy and gooey? Yeah, nasty stuff. It's got to come out. Got to come out. So incise and drain, curette out the dead bone. Get your culture specimen. Put them on their antibiotics and keep them under close follow-up. Any questions about osteomyelitis? Do you think you would have a suspicion? Would you be able to tell this apart from radiographic changes for dental granuloma or dental abscess? Granulomas and abscesses are localized and not multifocal or generalized. So you should be able to tell those apart. Is that fair game? Okay.
Can you repeat that one more time?
So when we looked at our diseases, our periapical lesions last week, when we have a dental granuloma or radicular cyst, which looks the same, or a dental abscess, they're always localized. They're fairly well defined at the apex. Sometimes they get kind of big, but they're solitary and round to oval, and they're not bits and pieces of it all over the place. Some here and then fairly normal and some there. So those are never moth-eaten.
Okay.
Whereas our osteomyelitis tends to be more diffuse and moth-eaten in appearance, more spread out. Yeah. So we have lost containment when we have osteomyelitis, and that's a key feature of the disease. Our other disease that we talked about with our pulpal and periapical diseases that was inflammatory origin, we'll mention again. This one we covered pretty well, but we'll still go through it again, and that's condensing osteitis. Condensing osteitis is the one periapical bony lesion that we see associated with teeth being stimulated by a problem in the tooth where the tooth is alive when this starts. Osteomyelitis and dental granulomas and dental abscesses are always associated with teeth with necrotic pulps, where the dental infection killed the pulp. But condensing osteitis is a reactive change in the bone that occurs in a tooth that has a vital pulp but a sick pulp. So there's pulpitis, and the inflammatory mediators from the pulpitis, from the inflammation in the pulp, go to the bone and stimulate this host response trying to contain it, beefing up the bone, and we get increased size of the trabeculae and gradual increased opacity of the periradicular bone in the affected tooth. So when we see this change at the apex, we need to always look at the top of the tooth and see if there's a reason for it to be present. So classic changes are opacity in the periapical area. It will fuse with the lamina dura of the tooth, and it kind of has a superimposed trabecular pattern, and the edge of it is a blending border, so it just gradually blends with a normal trabecular pattern around it. When we look at the tooth that has this periapical change, we should see some reason for pulpitis to be present. Either a major, huge restoration that could be encroaching the pulp, or huge caries that's encroaching the pulp. So is a full crown something that is a huge restoration? Yeah, and you don't really know what's under it, but you know they only place those if there's been a lot of loss of tooth structure. So anytime a crown is placed, there could be pulpal encroachment. So that makes sense. It totally makes sense. If you see this type of radiographic change around the root of the tooth and you look at the crown of the tooth and there's nothing going on there, it's not condensing osteitis. It's got to be something else. We should be able to see a reason in the tooth for it to have pulpitis. The other thing is that if the underlying problem in the tooth is not treated, pulpitis over time can pass the point of no return, and we can get pulpal necrosis and other patterns of periapical disease. This patient shows a little bit of widened PDL. That tells us this pulp has died. But when the process started that produced the bony changes, the tooth was still alive. Do you think this happens quickly? You are correct. It usually takes months to years, a year or two, but at least 6 months to get these changes. It's not something that happens in a day or two or a few weeks. This one I kind of don't like because it's in a patient with that really thin mandible area, and it looks like this is the pathologic area, but this is the lesion. And it looks more pronounced just because the normal bone around it is very, very thin and a little more lucent than we expect. But that's an area of condensing osteitis. And this patient, I don't know if you can see it, but this is an abutment for a bridge, fixed partial denture. It's had recurrent caries, and they patched it on this side, but they didn't do anything about the open margin and caries on this side. So it's got some pulpal problems. And we just see some vague increased density around the root. Do you think you'd pick that up? Should I use that one for testing? No? This is when the dentist should be picking it up, though. This is early condensing osteitis, and this is the time to intervene before the tooth dies. So hopefully somebody will recognize that things are changing, especially if you have previous radiographs for comparison. Yes?
Is this information just supplemental to the condensing osteitis that we already have?
This is planned redundancy, yes.
Okay, perfect.
Planned
We see
redundancy.
this all the time.
And one of the reasons it's planned redundancy is because condensing osteitis is radiographically indistinguishable from idiopathic osteosclerosis, which is a different disease. When I was in dental school in the 80s, they called all of it condensing osteitis. But somebody really, really bright finally figured out that we were seeing a lot of lesions that looked radiographically like condensing osteitis associated with totally normal teeth that had no pulpitis, and that we were really working with two different disease processes. So the lesion that's associated with normal healthy teeth is called idiopathic osteosclerosis. Increased density of the bone around the tooth in the tooth-bearing region of no known origin, and that's why it's idiopathic. We've been looking at these a while, especially since CBCTs came out, and we can see them three-dimensionally. These are always areas of increased density of bone that connects to a cortex. So it creates a track. So we believe that it's a physical buttressing effect for a tooth that has abnormal physical forces and is not susceptible genetically to get tori, so they get this instead. So it's like an anchor that holds the tooth in place, and we almost always see a little bit of tipping or heavy wear facets on the associated teeth. This is much more common than condensing osteitis, and any of you who got Isbin's paper book, the one example they have of condensing osteitis is actually idiopathic osteosclerosis. So she's old school like me and forgot that it has a new name. Idiopathic osteosclerosis usually develops in young people with virgin teeth or maybe minimal caries, minimal conservative restoration. And it's much more common in the mandibular bicuspid area where the bone is thin, not as good mechanical support for teeth. Sometimes the molar area, completely asymptomatic, normal bony contours, but it looks basically the same as condensing osteitis, an area of increased density, fuses with the lamina dura of the tooth, and sort of has a blending or feathering border at the edge. See? Those are nice examples. And you look at the crown of the teeth, they're virgin teeth. No decay, no restorations, no problems. Maybe this one was caused by the third molar pushing on it. Maybe. I don't know. Interesting. Yes?
The key difference when we're looking at these is there's no caries.
No reason to have a pulpal problem. There is no excuse for pulpitis. So you always have, when you're thinking, is this condensing osteitis, is this idiopathic osteosclerosis, you have to look at the bone and you have to look at the tooth. If you don't look at the tooth, You only have a 50-50 chance of getting it right. If you want to increase your odds, always call it idiopathic osteosclerosis because that's more common. But, you know. Do we need to biopsy this? No. Do we need to biopsy condensing osteitis? No. They're radiographically diagnostic and we just need to treat the teeth. If it's condensing osteitis, you treat the tooth. You do root canal therapy or get rid of the caries or whatever you need to do so the pulp is healthy. If it's idiopathic osteosclerosis, look for occlusal problems, do orthodontic treatment maybe, but you don't have to do anything for the bone lesions themselves. Will they go away? Sometimes yes, sometimes no. The literature is conflicted on this point, and sometimes they stay forever. Even after the tooth is extracted, and then we call them a bone scar or residual osteosclerosis. But they're really cute. These you're going to see all the time. These are actually extremely common in the general population. So, and we're done. We will pick up with fibroosseous lesions on Friday. Do not forget that Friday we start at 8 o'clock because of the hooding ceremony at 11 that I have to line up for at 10:30 and because you guys get to help prepare for the pinning. Yes, we have lots of fun things on Friday. It's off. My recording is now off.
Are you going to post the PDFs, or are they going to be posted for Jocelyn's?
They should be soon. I have a meeting with Dr. Grundy right after class. I will remind her she and I have been.
Yeah, gotcha.